Welcome to Psychiatry Grand Rounds. This morning I have the pleasure of introducing Dr. Ramsey McGowen, our speaker. Dr. McGowen completed her education at Auburn University, where she received her bachelor's, master's, and doctorate in clinical psychology. She trained at Memphis Clinical Psychology Consortium, and she is the Associate Dean for Curriculum at Quillen College of Medicine and a Professor Emeritus at the Department of Psychiatry and Behavioral Sciences. Please welcome me in joining Dr. McGowen.
Thank you. So it's nice to be here. Thank you for the invitation. Thank you for being here, listening, interacting. I think we can cover some interesting material and stuff that we can all put to good use. The requisite disclosures, I have none, no conflicts of interest or other disclosures to reveal. And the objectives are written on your evaluation form, so I won't go over them item by item. I will tell you the first two are background information, and we'll go through those kind of fast, but it's just to make sure we're all thinking and starting from the same place. Objectives 3 and 4 are going to be the meat of the presentation. You'll notice that they focus on how we teach about social determinants of health, not on what they are or how they affect health. So we're focusing on the teaching aspect of it. And then finally, Objective 5 is just a little plug for accreditation issues, and that'll be quick. It'll be a very specific slide, but there are 5 specific societal issues that we focus on in terms of documenting the coverage of societal issues in our curriculum. And we all need to be aware of those. So social determinants of health is a hot topic. It's something receiving enormous amounts of attention over the past 15 years or so especially, and it has become crucial and central in terms of understanding what we need to prepare students and residents to do in the practice of medicine of the future. We have blue ribbon panels, we have white papers, we have really important organizations. This is on the left is the National Academy of Sciences, on the right is the AAMC, talking about how it is we go about trying to deal with this, because it is a matter of some urgency to get this information incorporated into our teaching so that trainees can learn it, so that they can practice medicine in a way that's informed by it. So in an academic presentation, you always have to define your terms, right? We need to make sure we're all talking about the same things. So I'll start with what I consider sort of the default definition of social determinants of health, and that is really what we're talking about are the social causes of good and bad health. Just the social causes, not the biological, psychological, not other things, but the things that emanate from the social environment and social conditions. Now that's not the formal definition, and probably it's important to know what that is as well. So the World Health Organization is the one most commonly referred to, and you can see that it has 2 parts. The conditions in which people are born, grow, work, live, and age, and an expansion of that to clarify that the conditions include the forces and the systems that actually shape those social conditions. And they go on to clarify that that includes political systems, economic systems, social policies, all those kinds of things, and close with the statement that these social determinants, as defined this way, are most responsible for health disparities that are seen within and between countries. It's a pretty broad principle and issue that we need to be concerned about. Now, there are problems with this definition when it comes to applying it to teaching, and that's one of the things we'll talk about. But now everybody, I hope, has a shared understanding of what we're talking about. So let me back up for just a second. I'm going to ask you a question, a little icebreaker question, and just for a show of hands, then we'll come to this later in the presentation. But right now, before we begin, I want to know who in this room has ever focused on a short-term goal to the detriment of accomplishing a long-term goal. So you have studied for the test tomorrow instead of reviewing all your material. You have focused on preparing the presentation you have to give at the end of this week instead of meeting a deadline or preparing a lecture that you give in 2 weeks. You have short shrifted yourself on sleep. You have skipped a healthy meal or an exercise workout. Show me again, who in this room has done that? Okay, everybody in this room has done that. Okay, remember that. Everybody in this room has done that. So now we're going to move on. And this is just a story to give us some context. So please listen. I want you to think about Daniel and Jeremy as we go through the information about social determinants. So Daniel and Jeremy were friends in early childhood. They attended one of the better preschools in town. They both made good grades in school. They were well liked by their teacher and peers. Now they're in their mid-30s. Both of them are of average weight. Neither of them drinks to excess, uses illicit drugs, or smokes. Daniel's family lived in that same neighborhood his entire life. His family experienced some routine stressors. His parents went through a tough patch for several months, and that was stressful in the family. His older sister went through a period of fairly pronounced rebellion that was tough on the whole family when she was a teenager. And Daniel's grandfather died when he was 17, and he was very close to his grandfather, and that was pretty disruptive for a little while. But after each of these stressful events, the family stabilized. Both parents remained employed throughout Daniel's life. He participated in extracurricular activities, graduated, went to college. His parents helped significantly with his undergraduate medical education. And he got a job and now has been successful in his career as a mid-level city municipal administrator. Things went a little bit differently for Jeremy. Despite starting in this solid middle-class neighborhood in stable surroundings, his father was killed in an automobile accident when he was 6. His mother could no longer afford the family home in that neighborhood, and so Daniel, his 2-year-old and 4-year-old sister and mother moved in with his grandmother in a less affluent part of town in a 2-bedroom apartment. This move meant he went to a different school, one that had fewer resources. He was the new kid, so he was bullied as the new kid. His mother ended up working 2 part-time jobs, neither one with benefits, to try to support that household. And Jeremy ended up doing a lot of childcare for his younger siblings, to the point that as his grandmother's health failed, he ended up missing school occasionally, and he ended up dropping out of school in the 11th grade to get a job and support the family, even though academically he had always aspired to be an engineer and had been informed that he certainly had the potential to do that. So I just want you to remember Daniel and Jeremy as we go through this presentation. I've given a formal definition of what the social determinants of health are in sort of an abstract way. I'd also like to have you think about what these are in very specific terms. So we're talking about early childhood adversity, we're talking about community conditions, we're talking about the built environment in terms of the infrastructure that's there for health in terms of green space or zoning laws that have to do with what kind of standards there are for housing, crowding, crime, all those kinds of things. Remember, the World Health Organization definition talks about the social forces and policies that shape the conditions that people live in. So this is how that translates into the kinds of things that we're talking about with social determinants of health. Again, I'm going to focus on teaching. I just want to make sure we're all thinking about this the same way. I also want to ask you to stipulate a few things for me. Just like in geometry, you don't have to reprove something that's already proven. All the angles in a triangle are going to add up to 180. There are some things that I will not be proving today. I'm going to ask you to stipulate. There are things that you can go to the literature and find, and one of those is that non-biological factors contribute more to health and disease than other factors. We have adequate evidence for that. This is the way it's most commonly attributed in terms of the factors affecting health and disease. We know that traditional medical education does not adequately address these factors. We have a whole movement about how we should go about doing that, and that's one of the reasons I'm presenting on this topic today. We know that when we have tried to address non-biological factors. Up until now, we've tended to focus on the individual and on things like behavior change and focusing on skills for the individual rather than understanding what some of the social forces are that we need to address. We know that the cost of failure is high. We know the cost of failure in terms of the economic cost to our national economy in terms of healthcare expenditures. We know the cost is high to individuals in terms of their life, in terms of mortality, life expectancy, in terms of quality of life. And we know the cost is high to us as clinicians because we end up spending time dealing with problems that are chronic in nature because we haven't had interventions that allow us to target treatments at the right level. So we end up not getting the outcomes that we want. A couple of other givens. We know that emerging models of healthcare are going to focus on things like looking at outcomes, looking at quality improvement, looking at cost benefit of care, and we're going to be measured on those. And we also know that medicine is paying increasing attention to social accountability and the social mission of medical education. It's embedded in our mission statement. It's embedded in the professional statements of all the societies related to the practice of medicine. And so for all these reasons, we need to be addressing how we come to incorporate this and deal with this both in educating students and residents and ourselves and practicing in a way. And I said I would throw in a little plug for accreditation. I am not saying we should be teaching this because it's an accreditation requirement. That is not what I'm saying. That's backwards. It's an accreditation requirement because we should be teaching it, because we know that this information is crucial for our future physicians to be practicing effectively in the way medicine is going to be practiced in the future. So LCME wants to know we are preparing our students well. That's why they have an accreditation requirement saying, show us that you do it. And these are the society, so it's kind of a silly little point, but in order to show LCME that we teach on these topics, they say pick any 5 topics you want and show us how your curriculum reflects preparing students in prevention, in diagnosis, in treatment planning, and patient education around those societal issues. And the Medical Student Education Committee has selected these 5 for our curriculum. Doesn't mean we only teach these 5. It just means when we document our curriculum, these are the ones we will be reporting on. So it's good to know that in your role as teachers and educators, to know that in specific terms, we will be looking for this material in our curriculum. That's all I'm going to say about that. So number 5, objective 5. You know what the 5 are. So now I'm going to talk about some of the factors, really the heart of the presentation. The factors that affect how we educate people, our trainees, our students, and ourselves about social determinants of health. So I'm going to cover 4 specific things, the traditions that we have and what we typically have taught in medical education, the mindsets we bring to our students and to our preparation of material, the status of social issues in medicine, and the focus of transitioning away from knowledge-based measures of learning to skills-based. So quickly, remind us that although we have been talking about the biopsychosocial model since the 1970s, the legacy of the biomedical model is still very strong. It focuses on understanding things through linear causation, reductionism, sort of dichotomous either or, clear distinctions between cause and effect. That leads to seeing health and illness as differences at sort of polar opposites instead of on a continuum. And the implications of that are that historically we have done sick care. We call it health care, but we really don't focus on health. We focus on disease and trying to repair the damage that's already there. The movement now is for medicine to focus on health, which has to do with focusing on well-being, adaptability, resilience, all those other things. If all we do is sick care, then, and we have this dichotomous thinking as though they are different things, we are not going to accomplish that goal. In addition, the legacy of the biomedical model has led us to have very limited consideration of complexity. So rather than simple A causes B, when you look at the World Health Organization definition of social determinants of health, you end up with this network, this dynamic, complex network of forces that operate as a system. And you can't pull or affect one part of a system without affecting another part. So they are not independent of each other. In the biomedical model, social factors were confounding variables. We tried to control for those and get those out of the picture. But in fact, we are coming to realize that they exert their own independent forces that we need to try to understand. And we don't consider them things that we need to get past. We need to actually understand their direct impact and influence. Because we have this legacy, because we don't have a good way yet to educate students about complexity, students don't know what to do with this information, and we end up with reports like this. It's very nice. It makes us feel good to talk about poverty and compassion and dealing for the less advantaged. It feels good. But ultimately, it makes no difference in what we do for patients. And that's the part that has to change. It's not just a feel-good topic. It is crucial for the health of our nation, for our patients, and for the health of our profession. And so we want to get to a new place where ultimately it makes an incredible amount of difference. One way that that's happening is with new models of healthcare, where students and residents are being trained in systems that incorporate social factors into the delivery of healthcare. So you get something like social services integration in a program called Health Leads, where representatives of service agencies that can facilitate dealing with social determinants are actually embedded in a primary care clinic, and the physician can write a prescription that says, go, you need transportation assistance, nutrition assistance, whatever, and you take that to the representative, and they are there on site reducing a barrier and facilitating dealing with the issues that are contributing to our patients' health. So the Health Leads organization talks about these social determinants as upstream factors. And one of the stories is that the story of a patient they had in Health Leads named Veronica. She had a chronic, debilitating headache, went to the emergency room, had an extensive workup. No cause was found. She was given some pain medicine and sent home. Couldn't get an appointment in a primary clinic for 5 weeks. She went back to the ER 2 more times, continued to be told there wasn't a cause, sent back home. When she finally got to the Health Begins clinic, in addition to having her vital signs taken before the physician came in, she was met with a health worker who did an extensive social history and asked, tell me about where you live. And it was determined that she lived in substandard housing where there was standing water, pest infestation, and mold. And those 3 visits to the emergency room, the time that those emergency physicians spent trying to determine a cause, were all for naught because it wasn't what we typically think of in our differential for chronic headache. Also, the Geisinger system has recently adopted for their patients with type 2 diabetes a food-centric as opposed to pharmacy-centric approach to managing type 2 diabetes. And they actually have a food pharmacy where the patients go and actually get a week's supply of food or 2 weeks' supply of fresh food, fresh produce, and healthy food, instead of telling them you need to eat more whole grains and fewer simple carbs and more fresh fruit and vegetables. They actually give it to them. They say, take this home. This is how you eat it. The Results so far suggest that for about a $1,000 investment, they are netting anywhere between $8,000 and $20,000 savings to the system. They typically see an average of a 3-point drop in A1C, which is huge, just by dealing with the fact that the patient's ability to follow the diet plan that they need to follow with type 2 diabetes has been accomplished by embedding it in with the traditional care. This is just what health leads use, an example of screening instruments that can be used to screen for social determinants of health. I'm going to take a little more time to talk about the mindsets that we bring into medicine. And this will be in some ways consciousness raising for us as educators because they affect us as much as they affect our students and residents. And so we've already talked about linear causality. I'm going to talk about the cultural lenses that we carry around with us. Most of you probably know about implicit bias, but there are other kinds of cultural messages and narratives that we absorb that affect our understanding of social determinants and therefore how we teach it. Talk some about implicit attitudes and framing. So every culture has multiple narratives. I'm not saying the United States only has one. So we have multiple narratives. Two prominent ones are the benign community. We are a caring society. We look out for those in need. We help each other in times of distress. We pull together when a hurricane or an earthquake causes disruption in social lives. We care. But the other narrative, and this is probably a stronger one in the United States, is the narrative of the rugged individual, the self-made person, that anybody can go as far as they want to go if they just put their mind to it and do what they need to do to succeed. And so I'll talk more about that and also about this mentality of sort of zero-sum thinking, which we fall prey to more often than we should. So in terms of individual responsibility, this is some research from the Robert Wood Johnson Foundation, survey asking people to what extent they felt like they had control over their health. And people feel like, you know, very strongly, I make the right choice. If I make the right choices, I can control what my health is. I can control the outcome. By extension, the psychological principle would be called sort of the just world hypothesis. If I can control my health and get good health as a result of my own efforts, you can too. If you do the right thing, you're going to get the right result. So in some ways, this assumption of individual responsibility leads us to think in a negative way about people who don't have good health, because we attribute it in some way to their own doing. Am I saying that individual responsibility does not matter? Has anybody heard me say that? No, I am not saying that. Individual responsibility matters. Every person should do everything that is within their control, realistically possible, to engage in good health practices. What I'm saying is individual responsibility itself is not enough. It's an incomplete picture. And that's why we need to look at what some of the social determinants of health are doing to contribute to the outcomes that we see. So how this shows up in medicine shows up in quotes like this. Patients aren't responsible to themselves. They aren't responsible to me. I try my best. I give them a perfectly good treatment plan. Then they don't come up. Then they get more sick. Then I have to deal with them again. Fosters resentment. And the underlying assumption here is that they could have done better if they had wanted to. They're not responsible. We need to start thinking about what other factors other than individual responsibility might be at play here, whether it's social conditions related to the availability of transportation or childcare, or money to come in for visits, all kinds of things, instead of just assuming it's individual responsibility. And remember Daniel and Jeremy? You guys remember Daniel and Jeremy? The story at the beginning, bless you. I want you to think about them as I show you the following graphic. that is a traditional teaching graphic developed about health disparities that's used, and it was developed by some very knowledgeable people. So it's a graphic designed to help people understand the difference between equality and equity. Equality is giving everybody the same thing. Equity is giving people what they need to succeed. And this graphic does a pretty good job of differentiating those two concepts. However, if you look at the graphic, it's the people that are differing. It's not the context, it's the people. They have, so the implicit message here is that the deficiency is within the person. The situation's the same, and they could, you know, so what that means is that fuels a perception that if the deficiency is within the individual, then it's a competition. Why should one person give to another person just because they're not good enough? There's this competing interest, and it comes across as, you know, one group being advantaged at the expense of another group. This is probably a more accurate representation and what we want to communicate to our students about equality and equity. Because it's not the people who are inherently limited or deficient. When we're talking about social determinants of health, we're talking about the social environment. So the fence is higher. Think about Jeremy. The fence is higher for him to get over to succeed in life. And he's starting from a lower place at the beginning in terms of how far he got in school. He didn't quit school because he was lazy. He quit school to help support his family. So, but that put him kind of behind behind in his ability then to advance. So that narrative about individual responsibility, although it's not explicitly stated, gets incorporated into the teaching tools that we use. So again, we have to become very aware and sensitive to how we carry forward cultural messages. So that's one thing. It shows up in what we teach in terms of risk factors. We often, when we talk about patients in terms of risk for complications, very often we talked about biological risks, past medical history, family history. We talk about maybe individual patient behavior, but we don't always talk about the social environment that puts our patients at risk. We tend to focus on the symptoms, again, providing sick care, and not the causes that need the intervention to truly result in the health outcomes we want. I'm also going to review pretty quickly some interesting research that I find interesting, and I think just informative in terms of us and our own awareness of how it is we understand factors related to individual responsibility. So, does everybody know the marshmallow test? It's, you know, give the kid a marshmallow, you can eat it now. If you wait, you'll get 2. And the experiment amounts to how long can the kid wait? How long can they delay gratification? Can they inhibit their impulsivity, just grab that delicious marshmallow and cram it in their mouth? There's a long-standing track of good research that shows that a child's ability to delay gratification early in life is predictive of all kinds of positive outcomes. Success in school, peer relationships, success at work, long-term longitudinal success. And the interpretation typically has been that the ability to delay gratification and inhibit impulsivity resides within the child. It's a skill that they have. And so if they don't have it, we need to teach it to them. So it's a deficit within the child. Am I saying that individual responsibility doesn't matter and that children don't need to learn self-control? I'm not saying that. I'm saying that there may be other things besides a deficit within the child that contributes to the ability to delay gratification. So some really clever folks at Rochester decided to redo the marshmallow test. And this is what they did. Before doing the marshmallow test, they had the children subjects go into one of two conditions. They came in, and all the kids came in, and we're told, we're going to be doing an experiment. We've got a little bit of time here. Here's some paper, and we've got some crayons and art supplies, and you can just, we'll just have a little bit of fun until we're ready to start. For half of the group, and the crayons that they showed them were, 3 or 4 beaten up, broken, used, crappy kind of crayons. For half of the group, the experimenter said, wait a minute. If you'll hold on just a second, I've got a brand new art supply in the other room, and it's really super cool, and you can play with that. And so the experimenter left and came back with this really terrific art supply kit that the kid got to play with. For the other half of kids, though, the experimenter made the same promise. If you'll just hold on a second, I'm going to go get this other art supply kit, and we're going to have a ton of fun. Came back and said, oh, I thought I had that, but I didn't. We don't really have, so you can play with these crappy crayons. Didn't say that, but, build the expectations up and then essentially break the promise. Create an unreliable environment where trusting that the future has good things if you just exert self-control, those kids learn the lesson that that may not be true. In fact, that was not true. So what do you think that did in terms of how the kids performed on the marshmallow test? Did it have any result at all, any impact at all? You've got it. What? Who went for it? They had an expectation that was dashed. They had an expectation that this would not pay off. If I don't take what I can get when I get it, it's not going to make any difference if I wait, right? So they learned a very different lesson about the benefits of delaying gratification. And you are right. The kids who were in the reliable condition ended up waiting on average about 4 times longer. So what does that say to you about where the ability to delay gratification resides? Is it just in the child? Or is it also in the expectations and the environmental consequences that children have experienced, that adults experience in an environment that has a big influence on the choices and decisions that they make? And then I'm going to actually go to this. Is anybody familiar with this? This is a really cool experiment done at Princeton by a behavioral economist and a psychologist. And they basically, so you remember that question that I asked you at the beginning about was there anybody who hadn't short-shrifted a long-term goal in order to satisfy an immediate goal, immediate obligation? They did some experiments looking at time scarcity. They basically had the group set up to play kind of like a Family Feud game. But instead of, so they were looking at scarcity. Instead of financial scarcity or other kinds of educational scarcity or whatever, they set it up for time. So one group had 15 seconds per round. The other group had 50 seconds per round, over 3 times as much time. And they allowed the groups to borrow time from subsequent rounds. And what they found was that in the time poor or time scarce condition, remember, these were Princeton undergraduates, pretty bright folks, probably people who knew how to make long-term goals and pursue them. But under the condition of scarcity, they made lousy decisions about time. They borrowed time from future rounds so that they ended up, just to get through this round, they borrowed time from subsequent rounds so they ended up with no time in the last couple of rounds. They made very bad decisions. So there's a whole body of research about how, and now I'm going to go back, how scarcity affects decision making. And so we know that those in poverty engage in poor health behaviors. That's pretty well documented. They have poorer food in their diet, lower quality food, less healthy food. They exercise less, they smoke more. The question becomes, in terms of why that happens. Is it because they are deficient in some way in making choices? Or are the conditions of scarcity such that people engage in short-term solutions? So it's been found that scarcity promotes short-term thinking. It focuses attention on survival, not on long-term goals. Just like we focus on survival when we have a lecture to give today at 11 o'clock. Was I doing things for next week at 10 o'clock last night? No, I was not, even though I should have been, because next week I'm really going to resent the fact that I didn't spend some time on that this week. So again, just this kind of research, both the reformulated marshmallow test and this kind of research thinking about scarcity, gives us a way to think about individual responsibility and the social context and put together a much more comprehensive, even if it's complex, understanding of how patients experience their world. Then we have issues related to, in terms of teaching, how we actually discuss these issues. So I'm going to show you, we're going to do a little competition here. I'm going to show you two very brief videos introducing the topic of social determinants of health. This is the World Health Organization. Each of them is less than a minute long, or about a minute long. So,
the bulk of the global burden of disease
hear that?
and the major causes of health inequity.
Now, what do I need to do about volume? I did not. It was set up when I got here, so. I'm used to a symposium where I can control the volume myself. So. What do you want to minimize that? I might have time to spend a lot of time getting it. Let me just go back. I'm sorry. This is, if you get a chance to, let me see what else we can do here. I'm going to try the other one. Actually, let's see if that helps any.
These, which are found in all countries, arise from the conditions in which people are born,
Y'all can't hear that,
grow.
can you? Okay, so let me see if this one plays. If not, I'll just describe it, which is not nearly as good.
Social determinants of health. Join the call to action.
Can't hear that
Health
either,
starts
can
in
you?
our homes, schools, and jobs. We should have the opportunity to make the choices that allow us to live a long, healthy life.
Okay, so I'll just go back, and unfortunately, if you get a chance to compare these two videos, I really hope you will, because they give the very same message in very different ways. So the World Health Organization message talks about the formal definition of what social determinants of health are, and goes on to use traditional language about health inequities, health outcomes disparities, that they are unavoidable, and he doesn't use the word immoral, but basically says unnecessary differences in health outcomes based on social conditions. And then the one from the Association of Academic Health Sciences Center gives the very same message in a very different, positive way. Talks about health begins where we, are born, grow, live, work, and play, and everyone should have an opportunity to have a healthy life. Everyone should have the opportunity to make good choices. So it is not nearly as judgmental. It incorporates both the idea of individual responsibility and social conditions, that our race and our income should not keep us from having equal choices. So think back to that graphic of the fence and the condition at which people start. And this, I think, shows part of the problem that we've had when we talk about social determinants of health. We've started with that language, that very formal language, that tends to come across as a little bit sanctimonious and judgmental and value-infused, when in fact we're talking about trying to produce good health outcomes, which is something we all agree on. And so we can talk about things in a way that make this information more accessible. It opens doors rather than shutting doors. So words that, when we talk about social determinants of health, words that trigger more positive responses and more interest in this are things like giving people a fair chance, giving people opportunities, providing tools, enabling choices, things like that. So there's a whole area about how we frame our messages in a way to make sure that people understand what it is that we're talking about. And I'll go over that in a little bit more. And then zero-sum thinking, which is also one of those things we carry forward with us. The assumption that we have limited resources and competing interests. And if you give to one, you have to take it from someone else because it's a finite pie. But if you have systems thinking and you understand that you can't change one part of the system without changing the other part, or if you think back to Veronica, who was going in and eating up ER time and expensive workups, we can all stand to gain by understanding the social conditions. Like she was living in a moldy, pest-infested home, and that dealing with that actually serves to benefit us as healthcare providers who can use our expertise in the way that we're trained to do it. So that's part of what we need to come to terms with in terms of how we present information in a way effectively. In terms of social issues in medical education, this is getting increasing attention, and we're developing models about how to teach this, and that's good. But there's still a little more bad than good. We know that as people progress through medical education and training, starting with medical students and going through residency, attitudes toward patients with disadvantaged backgrounds become more negative. Attitudes toward homeless patients, impoverished patients. We know that happens. And I have some ideas about why that happens, both in terms of the location of our medical education and training and hospitals that separate trainees and patients from the context that patients are living their lives. Some of it also has to do with the timing of education. So timing, we tend to teach this as knowledge in the first part of medical education. So we teach people to know about social determinants, but we don't put it into the clinical years where people learn what to do, what skills they can use to make a difference. So it's very disheartening to know we've got all these things here that we need to be trying to address. We don't have the skills to do it, and we haven't gotten a model to know how to really understand how this works. And it's very easy then to just sort of say, I don't care about this, or it's too much, or it just gets, treated as unimportant. So you remember that first when I talked about students don't know what to do with this information, that publication by students that said it's nice, but ultimately it makes no difference. We can't have that. We can't expect students and residents to think it makes a difference if we don't show them how it makes a difference and how to go about doing that. So, so some of that's working in inpatient settings more than outpatient or community settings where patients are detached from their living environments, where we see people in discrete episodes and not what happens in between. So that health worker with Veronica knew that based on her address, she was likely to live in substandard housing. But if we don't have health educators and health workers in our clinics that know the community, then we're not likely. So that was the first question out of her mind. Tell me about where you live, because I know in your neighborhood this is likely to be a problem. So another thing that happens is we give incomplete causal narratives. So we may talk about genetic risks or past medical history risks, but we don't always include in the causal narratives of how a patient got to where they are now the factors associated with their social conditions. And that also can help. When we ask students and residents to give a formulation of a case, asking them to fold that in and then asking them what we can do about it is a big part as well. So I'm going to close up with some very specific, this has been kind of a broad brush overview of social determinants and what some of the issues in teaching are, but I'm going to close with some very specific suggestions. The first thing I think we need to do is get organized. We need to have a team that understands how this pertains and is relevant to our students and residents, how it's pertinent to the practice of medicine. We need to practice medicine and healthcare in a way that begins incorporating some of these new models. We need to use the best language, not language that closes doors, but language that opens doors. We need to define our terms clearly and not leave them open to vague interpretation and prior associations. We need to provide a very practical alternative to help students have a scaffolding to hang this information on. So here are two. I'm going to show you another one that's actually my favorite. It's not intuitive. It's not intuitive to know what the alternative is. And unless we can give people a scaffolding to use this information, it's going to just float around in the breeze and eventually get blown away. And then we need to challenge assumptions and implicit attitudes about just individual responsibility. It's not that individual responsibility doesn't matter, it's that it's incomplete. And relate, I'm going to give a little bit more of this, to sort of how biological, social, and psychological really have to all be considered simultaneously. So it's kind of like someone who gardens. If all you did was think about what seed you had, and you didn't think about the soil you planted it in, is it sandy or clay? Does it have good drainage? Is it have the right balance of nitrogen and phosphorus for the kind of plant that it is? Does it have too much sun or too much shade? If you only look at the seed, you're not going to really understand why you get the output you do. You need to look at the soil and the environment. And that's what we're talking about with social determinants of health. This is the conceptualization I like the best, just because it's clean. It has some remnants of linear thinking on it, but it really allows us to start thinking in terms of a system. It talks about health not just as a length of life, but as a quality of life. So I think we can use this, or there are many models we could use. The bottom line really is we need to have a practical model for students to go forward with. These are some of the results from Robert Wood Johnson in terms of communication strategies and just ways to say the very same message, but to say them in a way that allows people to feel receptive and like it's a topic that's pertinent to them. I meant to say at the very beginning, the title of this is We Can Do Better, and that is not intended to be scolding, like you can do better. It's, the emphasis is on the can. We can do better. We can. We know some of the things we need to do. We know the directions. So this is intended not to be scolding, but to be encouraging. We can tie together social determinants of health to the traditional medical sciences. So we can talk about how social conditions relate to gene expression or inhibition. We can talk about the neurobiological consequences of early life adversity, or about positive life experiences, about positive social environments and how those contribute to health. So we can talk about, there's one school that talks about implicit bias, not in a course over here about professionalism and attitudes toward patients, but talks about implicit bias in their neuroscience course when they're covering the limbic system. I think that might be the way we should go. You know, in terms of how we process information over our lifespan and form attitudes and memories and emotional reactions to things, maybe if we put it in the neuroscience course, it would resonate. I don't know. We can offer practical solutions. We need to teach protective factors and prevention and strengths in addition to risks and deficits. We need to promote the positive determinants of health. So for each of those things on that early list that I showed you, that this is what we're talking about in practical terms, education, built environment, stress, community, all those things, for each one of those, they can go either way. They can have an adverse effect on health, but they can have a positive effect on health outcomes. And to the extent that we can teach people how to promote positive health outcomes through positive determinants of health, we're offering a much more optimistic message. And I think a lot of times students, especially I'm more involved with students, walk away from information about social determinants of health thinking, what am I supposed to do with this? How can I make a difference in this? And what I would say is we're moving toward new models of care that involve teamwork, that involve not one patient and one physician, but also looking at populations and larger focuses of social responsibility. So we need to prepare our students for all those new models. But we also need to say, you're right, we don't know exactly how we're going to get this into the physician's skill set effectively. But we know we have to if we're really focusing on health. And so this is a challenge. We need to figure it out together. Medicine has solved seemingly intractable problems as a profession before. So it's not a slam to say maybe we don't know how to do it the way we should yet. It's a challenge to say we need to keep working. The American Medical Association has put together what they call the third pillar of medical education. The traditional pillars are basic science and clinical science. They are now promoting something they call health system science. Many schools have adopted this. It's a way of, as the third pillar of medical education, of where the medical education of the future will be. There's a really neat textbook they put together that summarizes some of how all this information about new models of care delivery, about the role of social determinants in terms of healthcare policy, which again, policy is part of what the definition of social determinants of health are. We need to improve the causal linkages and how we understand health and disease. We need to teach probably in some different ways, so there are games related to the social determinants of health. This is a picture of something called a poverty simulation. It's a half-day experience where students are assigned roles. They may be rich, they may be poor, they may have certain resources, they may have a broken down car or a good car, but anyway, they're assigned a role, and then you set up sort of a mock community, and you give them assignments to try to negotiate through the system. It's very enlightening. If you ever get a chance to do it, people walk away with a profound appreciation of how social experiences affect what they do. Choices they make, experiences they have, the health opportunities that they experience. We can use authentic assessment. So this is an OffKey case that's used at George Washington University. Same basic patient, same presenting complaints, same working diagnosis of acute pancreatitis. The only difference is one of them is working in a lower wage job and does not have health insurance. And the other one has health insurance and a more stable and higher income. And they include in grading the OffKey how well the students are able to identify the social determinants that are affecting what kind of treatment planning needs to happen for this patient and what the likely influence of those are. So we could do OffKeys that have our students understand. You know, they say assessment drives the curriculum, assessment drives learning. If we assess it, then all of a sudden it will take on some degree of significance. Long-term meaningful service learning has been found to be more embedded in the community with patients, is more effective than short-term episodic kind of service. Not community service, but real service learning, where it's tied to the roles of being a physician. Another thing we need to at least consider is how to have respectful, thoughtful, careful discussions about some of these issues that are very loaded. Most of the schools who do it longitudinally. It's not a one-shot thing. It's related to coming to understand oneself in relation to the social environment, self-awareness in terms of how that folds into the practices that we take forward in patient care. It is loaded and it's risky and it needs to be done carefully, and we need to learn from the people who have done it well. And that's sort of the closing point I want to make. We don't have to reinvent the wheel on all of this. We don't have to do it all at once. There are educational programs out there that we can study, that we can draw from. It's complicated. Social determinants are complicated, and the teaching of them is complicated. So here are some resources at the end. AAMC has 27 interventions for addressing social determinants of health. MedEd Portal has curricula to use about this. The AAMC Health Equity Research site has some resources, and the AAMC and the CDC produce joint webinars, so to educate ourselves, to incorporate some of that information with our teaching. We have ways that we don't have to start from scratch. And we can do better. This is important, and I hope I've persuaded some of you to think about it a little bit differently. And that's the end of the presentation. Be glad to have discussion. I really appreciate the opportunity to talk to you guys and have you here. So, any comments or questions? Yes? Right, this is for type 2 diabetes at Gessinger.
So what I wanted to know is that a one-time thing to kind of
No, it's ongoing.
So how long
I don't know how long the programs last. I think they have at least 1 year data. But the point is that a food-centric treatment of type 2 diabetes is probably long-term a better treatment plan than medication alone. And so when they can get A1Cs dropping by 3 points by food prescriptions, we probably have done better for the patients, better for ourselves, not having to deal with complications, and better for the healthcare system in terms of overall cost. So I don't know the details of how long somebody can stay enrolled.
So you don't know the ROI as far as a money differential with that intervention versus, say, regular standard of care? Kind of management?
The only real cost figure I remember is that they estimate a cost per patient, probably for a year, is about $1,000. That for every 1 point drop in A1C, they save about $8,000. And their patients had an average drop of 3 points in their A1Cs. So they're getting at, on average, $20,000 to $24,000 overall savings per patient.
The other comment was that, you know, the Blue Cross Blue Shield of Tennessee, the partnership promise, I've noticed that the questionnaires that they ask focus a lot on, again, psychosocial kinds of elements, including, you talked about control, you know, how much control do we have? They talk about stress, work stress, boss, you know, are you comfortable with your boss? Are you stressed with your boss? Things like, how do you view your own health care? And what access do you have, living conditions? So clearly it's getting picked up in terms of these areas being important in health considerations, because that's part of what the elements they're looking at. So I thought that was very interesting. I've never done those kind of questions.
Yeah. Tom? Don't ask a hard question, Tom. Don't ask me a hard question.
No. This is really interesting. Thank you very much. I mostly wanted to comment on a couple things. One is, I think the system complexities are so great that there's no way to encompass them within the scope of medical education. You know, for example, the things that create food deserts in communities are beyond medical education to deal with. Those are much bigger political and economic problems. I also think that it can
Let me just say, they are beyond the scope of sick care delivery and physician, but healthcare delivery can change. So Dr. Lura and I were in with a presentation by a student yesterday doing an alternative community medicine, whose project was how to improve health by promoting healthy lifestyles, including adding bike lanes that are safer for bicyclists. And he talked to the city planner, and so there are ways in terms of advocacy. It's not your front line, but it's not completely excluded from the role of a physician. And those 8 chapters, I think, kind of communicate how it is we can start thinking about that. So your second part?
So the second comment kind of relates to income, but it turns the issue on its head. And that is, I've been impressed with the extent to which current payment models are reinforced through the back door by the cost of medical education, so that people
Right.
finish school with enormous debt loads, and they have no choice
That's right.
but to practice in a system
Well,
that
they have a
also
choice,
only
but they don't have a reward for practicing in
Well, some of them may literally have
individual
no choice.
responsibility, Tom.
All right, they don't have a
Incentive.
an uncoerced choice.
Right, that's right. I agree with that.
And you know, and then we have a profession that is increasingly moving to a model in which physicians are employees, in which their outcome is not measured in terms of anything you're talking about here, but is measured in terms of traditional
Productivity,
sick
yes.
care metrics like
That's right.
RVUs.
That's right. And that has to change. That definitely has to. Payment models have to change. Delivery systems have to change. All of that. You're right.
Right. So how do we start that, given that our medical school itself runs on the back of a financial model that is based on RVUs?
Right. I was talking to my son who does chronic, assertive community treatment with chronically and severely persistently mentally ill people in Southwest Virginia. And I know it's after 12 o'clock. For those who need to leave, that's okay. It's going to be fine with me. But talking about the healthcare needs of the mentally ill that he works with, that Medicaid in Virginia will pay about $1,000 for a tooth extraction after it has abscessed to a certain point. But it will not pay for preventive care for dental work. It will not pay for eyeglasses. It'll pay for a toe amputation, but not for the podiatrist to prevent that. So payment models, yes. In terms of reimbursement systems, that may be, because it's 1204, maybe something for a later time. Whew, rescued. So other thoughts?
I was going to point out that in neurosciences, we are teaching this idea already in some ways. In particular, Sapolsky has been very direct about talking about the Dutch hunger winter.
Right.
And it's very interesting. The Nazis would not allow the Dutch access to food in the winter of 1943. And the number of people that went on to have metabolic syndrome was just huge compared
Right.
to the rest of the population.
Right.
And when they discovered this, they had gotten to the point where they were able to really look at brain connectivity data, and it's clear that the valuation areas of the frontal lobe dealing with scarcity issues, in this case, were modified early on in life,
Right.
never to be unmodified.
That's right.
So it's there, and
So,
you know, my comment was going to be the difficulty is, even though there's information like that out there, translating it into economic models that have to do with insurance
Right.
payment is just so impossible.
so we need to read this book in terms of how we translate that into how we educate people for practice that incorporates these. I skipped over some of the stuff about the life course perspective and how the origins of adult disease, especially chronic disease, probably largely reside in early developmental experiences, whether it's neurological or otherwise. So I think we're out of time, and I will wrap up. Anybody who wants to come down here and talk, I'd be glad to, but I'm really happy to have had this chance. Go and have a good lunch.